This program is brought to you by Emory University.
Good morning, everyone, and welcome to our last Heart and Vascular Grand Rounds, last but not least for sure. So today it is my pleasure to introduce a friend and a colleague, Dr. Ifeoma Onuorah, who is an assistant professor here at Grady since 2017. She went to medical school at the University of Texas San Antonio Medical School for internal medicine and residency at Hopkins, followed by a cardiovascular fellowship at Thomas Jefferson. Subsequently, she was a hospitalist for a year in Philadelphia, and then was also practicing as an internist at University of South Carolina at the VA before joining us here at Grady. She's been very active in mentoring and teaching fellows and med students, as well as ultrasound techs. She's very passionate about cardiovascular imaging and co-directs the stress and echo lab at Grady. She's going to talk to us today about a very interesting topic on cardiovascular disease and the homeless population. Ifeoma also has invited a guest, Leslie Marshburn, who's the Director of Strategy and Population. Hello, I see you. Thank you so much for joining us today.
My pleasure.
She is the Director of Strategy and Population Health at Grady, and she will be joining us for the discussion. Ifeoma?
Thank you, Pooja, for that wonderful, kind introduction. So this has been an interest of mine for a very long time. Certainly, given where I practice here at Grady, we tend to see quite a significant amount of this vulnerable patients. I have no financial disclosures relevant to this talk. This is my objectives. We will define the scope of cardiovascular disease among homeless persons, define risk factors that are relevant to this population, and discuss from practical, pragmatic patient-centered approaches for healthcare clinicians that are treating these patients. So I want to start off my talk with this quote from Mother Teresa, who needs no introduction. And it reads, we think sometimes that poverty is only being hungry, naked, and homeless. The poverty of being unwanted, unloved, and uncared for is the greatest poverty. So Stuart B. McKinley Homeless Assistance Act, passed in 1987, was really the first legislative bill from the federal government in providing federal funds to emergency shelters. And they define homeless persons as persons who lacked fixed, regular, and adequate nighttime residence, persons who live in a shelter or place not designed for human habitation. And the Health Resource and Service Administration further expanded this to include persons at immediate risk of losing their house, persons fleeing from domestic violence, who has inadequate resource to obtain housing, persons who are doubling up or squatting or even staying in temporary arrangements with friends and family. So these are some of the terms that I'm going to be using throughout my talk. The unsheltered homeless population, which makes up about 32% of the total homeless population. These are the persons that we sort of label as sleeping rough. So these are the persons that sleep out in the open spaces or public spaces such as park or the train stations. The sheltered homeless make up about 61% of the homeless population, and they are typically in the emergency shelters or safe haven or transitional homes. In addition, the chronically homeless individuals, they make up about maybe 10 to 15% of the population, so a smaller segment, but they're generally persons that have been homeless for more than a year, or have had 4 different episodes in a year, totaling 4 different episodes of homelessness in the past 3 years, totaling about a year in length. Unfortunately, they tend to have higher burden of substance abuse and severe mental disorders. These persons are a little bit more difficult, I would say, getting them off the street. So the homeless population is very dynamic and heterogeneous. It is very broad spectrum, anywhere from transiently homeless persons to chronically homeless persons. Unfortunately, at times it's very hard to quantify the exact number. The way the homeless population is counted here in the United States is the point in time homeless count. This is typically performed once a year at the end of January. Leslie was telling me about the one that she performed here in Atlanta. So generally, these are a team of volunteers. And she started at 8 p.m. at night, and then you drive throughout the city and count these homeless persons. And she was telling me she actually didn't finish till like 3 a.m. in the morning. So you can imagine that, to me, listening to this, it could be very, it's a lot of work. And you can easily miss certain homeless persons. So for instance, if you were to become homeless after January, you are not reflected in the count. And if you were squatting with friends or family, you're also not reflected in the count. In terms of, unfortunately, about an average of 580,000 people are homeless in the United States on a single night. And this is about a 2% increase from 2019. Certainly, COVID pandemic had a mighty role to play in this, given job losses. About 1 million Americans are homeless in any given week in the United States. And between 5 to 8 million people have experienced homelessness during the past 5 years. So this is the latest 2020 national statistics from Department of Housing and Urban Development. And what you can see after reaching a nadir in 2016, the population of the homeless persons here in the United States have been steadily increasing since 2016, and it's represented by the blue circles. Unfortunately, the number of shelter bed or sheltered persons have stayed the same, represented by the gray square. And that means that more people are ending up on the street, so represented by the green triangle. So this is the unsheltered person. So a lot of them are on the street. So in terms of state by state, the states with the highest housing costs as well as living expenses tend to have the highest burden of homeless population. Surely a lot of states in the West Coast, like California, Oregon, Washington, Arkansas, and Hawaii, and then New York on the East Coast. But interestingly enough, a lot of states in the Midwestern states, are starting to have increasing rates of homeless population. So homelessness affects everyone, everyone from all walks of life, whether from young to the very old. It is a predominantly adult single male population. They make up about 60% of the homeless population. People of color are significantly overrepresented, with 39% being of African-American race, 23% of Latino and Hispanic ethnicity, 5% are indigenous people, even though they only make up 1% of the total American population. So there's quite a significant burden of homelessness in this particular ethnic group, unfortunately. About close to 48% of the homeless persons are Caucasian. So how are we doing in the state of Georgia? About roughly 10,000 persons are homeless as of the last 2020 count. 59.4% are in the shelter versus 40% that are on the street. It is made up of majority of single adult individuals, followed by families with children, and then the chronically homeless individuals. The good news is that since 2007, Georgia has really worked hard on reducing the burden of the homeless persons here. And they've done a good job by reducing by 50%, almost 50%, compared to a state in like New York that doesn't look as, there hasn't really been a major change. Not that they're not trying. So what about in the city of Atlanta? There is about roughly 3,240 homeless persons within the city. It is a majority over the 24 age group, predominantly male, predominantly of African-American in race. And I took this picture out of an article written in JACE last year, mentioning that now the homeless persons here in Atlanta, there's more increasing visibility, so there is more of them. In part, with the COVID pandemic, certainly a lot of people lost their jobs. And then I think in 2016, 2017, the Peachtree Pine Shelter also closed. And unfortunately, all those homeless persons that used to seek shelter there were sort of, I would say, released into the street, although that there was some attempt to place them in housing, but that was a big shelter here in Atlanta for several years. So we know the homeless population is aging. This is a data out of HUD, again, from 2017. And what you can see is that over a span of 10 years, the age bracket of 51 to 61 has increased by at least more than 50,000 persons. Certainly the 62 and older is also increasing, although they increase a lot lesser than the 51 to 61. So the median age of a homeless adult is now 50 years of age. Some of the explanation behind the increase in elderly homeless persons include that this age bracket is the baby boomers, and they tend to have had a lot of economic and social changes, such as the depression of the 70s and 80s, as well as the crack cocaine epidemic. So they're more likely to have less economic safety fallback if they were to lose their position, if they were to lose their job, excuse me. It is estimated that the number of homeless adults more than age 65 in New York City is going to increase from 2,600 to 6,900 by 2030. And we do know, and there's been several studies done on this, that being homeless is going to accelerate the aging process. So if you take a 40-year-old homeless individual, they may have the same physical ailment as someone that's 80, or even look like someone that's 80 years old that's housed. So this is a study looking at the aging trend among homeless persons in 6 Northern American cities. They recruited about roughly 3,500 homeless individuals in 4 waves from 1990 to 1994. 1996 to 1998, 1999 to 2000, and 2003. And what you can see at the beginning of the study, the median age of most homeless persons were about 36, 37. But as time has gone on, here, the median age actually approached 46 years. And this was a last count, but the study last ended in 2003. And then now is about 50 years of age with the latest data. And it's not that these homeless persons are staying on the street longer and aging. Certainly there have been a lot more older or elderly persons that have lost their homes and have ended up on the street as time has progressed. So there are a lot of reasons why people can be homeless. Anywhere from poverty and unemployment, discrimination, especially people of color, incarceration, and being released out into the street without undergoing adequate rehabilitation and integration into the society, high housing costs, substance abuse, mental illness and PTSD, especially among our veterans, traumatic life experience, such as domestic violence, sexual abuse, and dysfunctional family dynamics. So let's shift gear and talk about cardiovascular mortality in the homeless persons. Overall, mortality is much higher in the homeless population compared to the general population. They're almost 4 times higher to die compared to their house counterpart. The median age of death is around 41 to 47 years of age versus 77 to 80 years of age if you are living in a house. They also tend to have higher prevalence of HIV infection, other communicable infections such as TB, substance and drug use, homicidal deaths, and certainly the constant exposure to the physical environment. So some of the studies that are put on here are from the, sort of a little older, from the late 80s to the sort of like late 90s. And the most common cause of death at the time was HIV infection, as well as homicidal death. But that has started changing recently. So there's been a shift in the mortality trend in that now drug overdose has replaced HIV with the advent of great heart medications for a majority of these younger homeless persons. In addition, death from homicide, probably in part with the crack epidemic, and all the other communicable diseases are also declining. So instead, cardiovascular disease is now the leading cause of death among homeless adults, age 45 and older. They also tend to develop cardiovascular disease at a much younger age compared to their house general cohort or counterpart. And then given that the homeless population demographic is mostly made up of male, more people of color, they're older, in addition to being homeless, we know that the burden of cardiovascular disease is only going to get worse in this population. So this is a study from Dr. Hong group in Canada, and they look at mortality rate among roughly about 15,000 homeless sheltered individuals. And what they found was that mortality rate from cardiovascular causes were almost 71% higher in these population compared to their general housed population. And the majority of the cardiovascular deaths were due to ischemic heart disease, certainly in part to smoking, which I'll talk about in a couple of slides. And then Dr. Braguet's group in Boston looked at mortality rate among homeless adults. And they studied about 28,000 homeless individuals over a 3-year period, recorded an average of 1,300 deaths, excuse me. And cancer and heart disease was once again the leading cause of death among adults age 45 to 64. And in that age bracket, the mortality rate was almost 5-fold higher compared to their general house counterparts. So this is a table from that study, and the leading cause of death arranged by age and gender. And what you can see in both men and women in the younger age bracket of 25 to 44, the leading cause of death is drug overdose. But as you start moving into the 45 to 64 age bracket, as well as the 65 to 84 age bracket, and what you see is now cancer and heart disease now dominates both in men and women. They went a step further and looked at mortality rates among unsheltered homeless adults. And like, as I mentioned, these are adults, persons that sleep rough or sleep in open spaces. This was a 10-year cohort study of about 445 homeless adults. And in that 10-year, they had about 134 deaths, even though that they were saying that the way the deaths were, so they may be that there were more deaths than this actually. But mortality rate was 10-fold higher in this population compared to the general population. The median age of death was 53 years of age. And as demonstrated by the table here, cancer and heart disease was once again the leading causes of death. So with regards to traditional and non-traditional risk factors that are relevant to this population, this was a meta-analysis from Bernstein group, looking at prevalence of diabetes and hypertension in the homeless adult population here in the US as compared to the general population. And what they found was there was really no significant difference in the overall prevalence, as demonstrated by the two figures below. Of note, the prevalence of diabetes and hypertension have steadily increased as the year has gone on, both in the homeless population as well as in the house population, although maybe a little bit higher in the homeless and a little bit higher in the homeless population, excuse me, but not statistically significant. In addition to, from that meta-analysis, once again, supporting that the homeless population is aging, the median age was about 45 years of age as about 2010. And this only means that the burden of cardiovascular complication and death in this population is only going to continue to rise. With regards to hyperlipidemia, the studies have been very mixed results. The total cholesterol and triglyceride may be lower in certain settings as a result of inadequate diet, poor nutrition, and food insufficiency, which is very common in this population, as demonstrated by this study here by Dr. Baguette's group again, looking at food insecurity and insufficiency among about 966 adults using the homeless healthcare clinic. And what they found was that the homeless persons were more likely to have gone a whole day without eating, about 68% versus 32% of their house counterpart. Have gone hungry recently in the past 1 month prior to this study being done, or survey being completed. And majority ate about 1 meal a day. This is compared to a good 52% of their house counterpart eating more than 3 meals a day. With regards to weight and obesity, in general, it is a little less common compared to the general population, but I think it also depends on what study you look at. In part due to poor nutrition, food insufficiency, as I mentioned in the previous slide, and also a majority of them won't have private transportation, so they're more likely to walk around. And these shelters in the morning, they're closed, and the homeless persons are asked to evacuate from the premises. So they're out walking throughout the city. Also, the ones that will sleep in open spaces, a lot of those parks, they are also told to not loiter, so they are sort of forced to keep moving. Unfortunately, the homeless population that are overweight, they obviously have limited access to exercise facilities to help in weight loss. So why is cardiovascular outcome really poor in these homeless individuals, despite them having the same rate of hypertension and diabetes to their house counterpart? This is in part that they're more likely to be undiagnosed, untreated, obviously also late presentation to healthcare, to see a healthcare provider. In addition, they have multiple challenges and barriers that they face. So lack of insurance and ability to pay their co-pay, fragmented care, especially the ones that are moving from state to state, lack of insight and mistrust of healthcare providers, especially when combined with mental illness. One of the studies I was looking at mentioned that the #1 reason that homeless individuals don't present to the hospital or see a primary care healthcare provider, is discrimination on the part of healthcare workers, and certainly added to low health illiteracy. So substance abuse is very high in this population. About 80%, up to 80% are active tobacco abuse. 1 in 2 will have alcohol disorder. Illicit drug use such as cocaine, opiate, and amphetamine is extremely prevalent. As we all know, these substances are associated with accelerated atherosclerotic disease, adverse cardiovascular outcome, and cardiac death. So this was a nice study from a group in Mayo, published last year, looking at cardiovascular outcome and rehospitalization among homeless persons admitted with acute coronary syndrome. And they looked at patients that were admitted between 2015 to 2016. And what they found was that the homeless individuals are more likely to present at a younger age for acute coronary syndrome. The median age of presentation was about 57 years of age. Interestingly enough, they tend to have lower atherosclerotic risk profile, but have higher prevalence of substance abuse and psychiatric illness. They were also less likely to undergo coronary angiography and revascularization, as demonstrated by the figure on your right-hand side. More likely to receive bare metal stent compared to drug-eluting stent, and overall less likely to be referred for CABG, and in general, just less likely to receive optimal care for the acute coronary syndrome. Certainly, I imagine that concern for patient medication adherence probably played a role in some of the decisions that were made in these patients. They were also more likely to be discharged against medical advice, and also tend to have higher rates of 30-day readmission after their index hospitalization, But when you drill down to it, the reason that they represent back is not necessarily cardiac related. The majority of them were due to psychiatric issues or problems. So the editorial that followed this study, the title just really said it all. To be homeless with a heart attack in America, that's a double whammy. And I put a picture of Skid Row there on your right-hand side. And this is, for some of you guys in the audience might be already familiar with Skid Row, but this is area in downtown Los Angeles. And it's had the largest stable population of unsheltered homeless persons for a very long time. It's been around since the 1930s. In addition, these homeless individuals are more likely to be socially isolated and have poor social support. And this has been cited a common reason for some of the homeless individuals that are super ED utilizers, as evidenced by this paper by Dr. Bassam, who is one of our emergency room physicians, where she talked about that some of the relationship that is forged with these individuals with the medical staff, because they keep coming in and out of the emergency room. So they know a lot of people know them, that these relationships can sort of serve as an avenue for emotional support that unfortunately they won't be able to get on the street. We also know that living alone is associated with higher mortality rates compared to if you have support. So this population also have very high burden of psychiatric disease, as I've alluded previously, tend to have higher rates of depression, anxiety, PTSD. In addition, schizophrenia and bipolar disorder is very common in individuals who are chronically homeless. And a lot of the psychotropic medications, such as SSRI, that we use to treat these psychiatric disease can also exacerbate risk factors for cardiovascular disease. So these are all the factors that sort of play a role into why cardiovascular disease mortality disparity exists in this population, down to the individual level, where you see higher rates of smoking and alcohol consumption, illicit drug use and dependence, psychosocial stress and depression from the environment, lack of social network, and then you add on to that the healthcare barriers and challenges that they have to face, such as not being able to pay their copay, very few providers that will see uninsured patients. Obviously, no money to pay for prescription if it is prescribed, the fragmented care, as I mentioned previously, poor medication adherence, late presentation to care, and no health illiteracy. So this was a really nice review paper written by Dr. Baguette that was published in JACC in 2018. And I really liked this illustration, and that's why I put it on here. But basically just summarizes why cardiovascular disease is the major cause of death among homeless adults, and certainly why the disparity also exists in these populations. So what are the practical, pragmatic, patient-centered recommendations for some of us that take care of these individuals? Most importantly, developing a trusted interpersonal relationship is the first thing. Avoiding stigmatizing questions. And in terms of risk modification, simple once a day is always the best. If you're treating them for hypertension, be mindful that some of the diuretic-based medication might not be ideal in these individuals, given lack of restroom facilities out in the open space, as well as if they're in the shelters, they also may have limited access to bathrooms there. Certainly the food that are in a lot of these shelter foods or food pantry may tend to have higher salt in them, so educating them about that. If they smoke, encouraging smoking cessation. One of the studies that I looked at actually mentioned that 1/5 of the homeless persons would like to quit smoking if they have adequate resource. So there is motivation there to quit smoking. Luckily, Georgia has a 1-800-QUIT line for free tobacco cessation product. And if they do use substances, refer to these substance abuse programs. If they need stress testing or any procedures, try to arrange that as much as possible in a timely fashion and group all those appointments in the same day to improve compliance. This might be difficult for some of us clinicians to know what things cost, but it does help to know if you're recommending it in this population. There are 2 volunteer clinics that I'm aware of here in the city of Atlanta that do offer a specialty service. Leslie might know more. So Good Samaritan Clinic and Mercy Clinic. I think Mercy Clinic is actually the largest. In terms of if they need procedures or treatment, we healthcare providers should minimize implicit bias on our end. And there's been even unsheltered homeless persons that have completely adhered to their medication if they understand the need for it. So as much as possible, individualize based on the clinical circumstances and of course on patients. It's good to know about what medication assistance programs that are available in your area. They do require a multidisciplinary, multi-collaboration effort. As well as their medical needs being addressed, their social needs also needs to be addressed. And what I've found interesting was about 89% of these homeless persons do have cell phones. So texting them for appointment reminders as well as texting them for refill can potentially improve follow-up and compliance. So this is Sheila McKinchy, if I'm saying her name right, but so she is pictured here on your right-hand side. So she was a Scottish activist who tirelessly campaigned for the homeless persons in terms of improving accessible housing and making affordable housing possible in this population. And I take this quote from her because I really like what she said, and I'll read it. People who are homeless are not socially inadequate. There are people without homes. And I think he also sort of reminds us that anyone can become homeless. Certainly a majority of Americans live from paycheck to paycheck. And it just takes losing someone's job to easily end up on the street because they don't have, a lot of people don't have that fallback or economic fallback available to them. So in terms of achieving equitable outcomes in these individuals, certainly policies addressing accessible housing, especially in areas with rising housing costs. We do know that homeless persons who enter housing tend to have lower mortality rate compared to their counterpart who remain homeless. Outreach-based healthcare is also extremely effective. So embedding healthcare services in places where these homeless individuals have to frequent out of necessity, such as the soup kitchen or the shelter. Mobile health clinic too is ideal. So we are coming to them rather than waiting for them to come to us in the hospital or in the clinic. The tailored healthcare model has also worked very great in these individuals. So it's almost like it's a medical home where they get both their medical needs and their social needs addressed at the same time on the same appointment. HPAC, which is through the VA, has had tremendous success in terms of getting a lot of homeless veterans off the street and rehabilitating them. One thing that has made it difficult to, certainly part of my research interest in this is being able to track and identify who these patients are. Luckily enough for us here at Grady, EPIC added social determinants of questions recently. And one of the questions is housing stability. And when you click on it, 3 questions will come out asking if in the last 12 months, that particular individual were not able to pay mortgage or rent. In the last 12 months, how many places they have lived. In the last 12 months, was there a time you didn't have a steady place to sleep or slept in a shelter? And that way, all these are non-stigmatizing questions. And That way you can sort of help identify people who are imminent risk of becoming homeless, or the ones that are homeless that may not feel comfortable telling you that they're homeless. So in summary, homelessness is a significant and growing issue in the United States. Homeless persons have higher burden of cardiovascular disease mortality and morbidity and mortality, excuse me. And this is related to multiple factors at play, such as having higher burden of psychiatric disorders, substance abuse, psychosocial stress, and healthcare access challenges. We know that the homeless population is aging. Therefore, cardiovascular disease is only going to get worse in this population, creating additional burden on the healthcare infrastructure. I believe we cardiologists and other healthcare providers, such as the oncologists, also with the role that cancer is also leading cause of death in these homeless individuals, have a huge role to play in improving disparities in these vulnerable patients. It requires a complex solution to a complex problem. And this would involve an integrated effort at an individual level, more aimed at preventing homelessness. So individuals who are substance users, substance abusers, or or fleeing domestic violence, providing them resource earlier on so they don't become homeless to begin with. And then moving up to more of a policy level, instituting affordable housing, and also a housing first intervention where individuals are placed in housing without them necessarily being free from substance abuse. I would like to acknowledge the great people I work at Grady, and also our research interest group, as well as Leslie Marshburn. And I will leave you with this quote, and I'll stop here. And Leslie is going to speak a little bit about the success that we've had here at Grady in terms of taking care of these patients, as well as some programs that are available here in the city of Atlanta. So I'll stop here and let her share her screen, and then we can take questions at the end.
I am Leslie Marshburn, Executive Director of Strategy and Population Health, and I've been at Grady for a little over 4 years. And part of our population health strategy is to address the health-related social needs of our patients so they can have better overall outcomes. And we identify those issues through our triannual community health needs assessment. And housing has come up as an issue that we see in our patient population. We did an analysis, this back in 2018, and about 6% of our patients that are discharged from Grady are experiencing homelessness at the time of discharge. So while it's not a 50% or more, that is a significant number of patients that have, as we've just learned, more adverse situations that impact their health. And I want to share this framework that we developed that illustrates what housing interventions are appropriate for what patients experiencing homelessness when they exit the healthcare setting, and who's appropriate for what, and where the services are available. So we do have at Grady a housing support navigator that primarily supports inpatient social workers and connecting patients experiencing homelessness to the right service. So a shelter is not going to be appropriate for someone who is cognitively impaired, wheelchair bound, has limited ADLs, et cetera. So this kind of continuum of interventions highlights what's available. So some patients will leave Grady and go to a shelter. We try and minimize that as much as possible. We do have access to a transitional housing program called Hospital to Home, and I know that the social workers at Emory Midtown refer into that program as well. So if you're practicing at another Emory site, you likely have access to this as well. I'll go in more detail on the next slide. We also have access to recuperative care, which is a program operated by Mercy Care, which is a federally qualified health center whose mission is care for the homeless. So if you're having trouble getting a patient into primary care at Grady, which we hope you're not, but if you are, Mercy Care is a great option. They also have a street medicine team that goes out and they offer primary care, psychiatric care, peer support on the street. And they do a lot of outreach, go and look under the bridges, find the patients, et cetera. And then the next level of care as you get more acute is the temporary medically supported housing. And we've identified this as a need, and we're working on solutions to solve for this, because they're the patients that are wheelchair bound, have limited ADLs. They're not appropriate for some of the lower level interventions, but they don't really need a personal care home, and they don't need nursing home level support. So this is a model that we're trying to solve for. And then your long-term interventions, whether this is rapid rehousing, they self-resolve, family reunification, or end up in a permanent supportive housing program through Atlanta Housing with the voucher that's subsidized by the government, with supportive services through Medicaid waivers, and so on. So just quickly, our recuperative care program. So this is operated by Mercy Care. There are 14 women's beds at the City of Refuge. It's a really fabulous space. It's, personal rooms with a shared bathroom, shared living space. The men's center, which has 19 beds, is at Gateway, which is the Homeless Services Center on Pryor Street, which is a great place to refer folks to for lots of different things. Recuperative care does have 24-hour support, which is what makes it slightly different than hospital to home. They've seen really great results. 41% of men and 75% of women were discharged to permanent supportive housing in 2020. And then the hospital to home program, the goal of this program is really to reduce avoidable utilization and transition folks into permanent housing and link them to primary care. This model includes the support of a community health worker, which we think are vital to individuals' success. It's shared housing. So there are 2-bedroom apartments that have 4 individuals living there. So it is not a good fit for everybody, but it has a lot of case management support, and there are permanent supportive housing, subsidized permanent supportive housing options once they exit that program. So it has a lot of great resources. We've seen great success in analyzing our outcomes for Grady patients. 57% had a successful housing placement in 2018. And we saw a 24% decline in ED and inpatient utilization and a 31% decline in cost comparing the year before enrollment to the year after enrollment. So we were really, really pleased with that. And we've had this program about 6 years, so and the results have been consistent. And then one other thing that we have been involved in collaboration with Mercy Care and Partners for Home, which is the Atlanta Continuum of Care for homeless services in the city of Atlanta. We developed we call it the Integrated Care Permanent Supportive Housing Pilot. So it's a housing voucher. So you get the subsidized housing, and you get the street medicine team that does home-based primary care and psychiatric care. We've just filled our last voucher, and we're looking forward to seeing the outcomes from this.
Great. Thank you so much for that wonderful information. And thank you again for joining us as our guest. I know it's early, 7:30. So now I'll open it up for questions for both of you. And Ifeoma, thank you. This was just, wonderful presentation, and thank you for highlighting this vulnerable population that, I think we're all aware of some of the problems, but not knowing how to, what kind of support is there is important. So thank you for inviting Leslie Marshburn to this.
And thank you, Leslie, too, as well.
My pleasure. And I'm happy to help troubleshoot if any faculty at Grady ever end up, in a tight spot. I can help direct you to the right person who can assist.
Mm-hmm. Ifeoma, what do you think about, one of the problems with the coronary angiography whenever we have a homeless person is, we used to worry about DAPT and the fact that what if they don't take their Plavix or can't afford their Plavix? But now, since DAP doesn't always have to be a full year, sometimes it can be 1 to 3 months. Do you have any thoughts about that, or any of our interventionalists who are on the meeting today? And perhaps they could comment on that.
So I would certainly offer it to them. As I mentioned, there are even unsheltered homeless persons who will adhere to their medication, even though they're sleeping in open spaces. And if that individual is going to be adherent, I think we should offer it to them. And then, like as you mentioned, now we're reducing the duration. So there's no reason that we shouldn't be placing more drug-eluting stents in these patients.
Mm-hmm. With the pandemic, it's probably, as you mentioned, it's easy to become homeless when you're already living paycheck to paycheck. And, this becomes a real issue, because you could have a patient who could afford their insurance and, had a home, and then all of a sudden they don't have availability. So, I've had actually several patients who've lost their insurance, and trying to figure out whether they're still able to see me or not. And Emory has a charity care model also, at least that I'm aware of, to help them get through at least for a few visits until they can find a job and get back their insurance.
Yeah, and I wonder, Pooja, maybe you can, because I would imagine that it's probably limited spaces, which is the thing that we see a lot. So some of the charity programs tend to be smaller numbers of people that are, allowed at that particular time to see healthcare providers, which I imagine is probably the same thing as at Emory.
Yeah. What are your thoughts about, one subgroup within the homeless population is the subgroup with the substance abuse, cocaine, amphetamine. I feel like that's a different, you showed that Mayo Clinic study where it showed that, traditional cardiovascular risk factor burden was lower, but substance abuse was higher in people who presented with coronary artery disease. I wonder if anybody's looked at separating, that subgroup, because that's where, a lot of us might feel like, trying to educate about low salt and, taking your meds, you're fighting a losing battle. I feel like if they keep going out and, have a problem with substance use, as opposed to the other subset.
I don't have substance abuse. That is a fantastic question, Pooja. So I did not come across that during my research, but I think that is a great area to investigate. I totally agree with you. And I think another thing too, there is data here, but there's still not a lot of data. So primary care and infectious disease has done a great job in terms of managing these vulnerable individuals. But I think us cardiologists and also the oncologists are kind of slowly getting on, sort of on the ball, I would say.
Mm-hmm. Did you come across anything about sex differences with men and women? And I was also curious as to what happens with children. When you become homeless, do they get to stay with you, or what happens?
So to answer your first question, and by the way, great question too. So the only study that I saw sort of men and women divided was this particular study, but it was really no different in terms of the leading cause of death being from heart disease or cancer in both men and women. I think there's one thing too, there's not a lot of study done in the postmenopausal women. So I really didn't find a whole lot. And I think too, in terms of the overall burden of the homeless population, so it is mostly men, and women tend to be a lot less, and they're usually with families as well. But yeah, that's another area too that I certainly look at. With regard to your second question, I honestly didn't diverge. I didn't really look into families with children, if they stay together or stay separate. I don't know if Leslie knows.
Yeah, it is really challenging when they're, in particular, when it's a male homeless parent with a child. If it's a woman and a child, there are often programs and shelters targeted to those individuals, but it's really difficult when it's a male parent and a child. There is a program called Our House here in Atlanta that takes families. They actually, I know that they have capacity right now, so if you know of anyone, we can help get them in. And we have a case right now in ortho where a mother needs a surgery and the 14-year-old minor child has nowhere to go. And we're working with DFACS to try and get a respite foster placement. They're currently living in a tent outside of the Walmart where they work. So it's where she works. So it takes a lot of hands to help solve these challenges and helping folks experiencing homelessness access care. And it's certainly all hands on deck now for that case.
Very challenging. Our guidelines that came out in 2018, 2019, for primary and secondary prevention, they have incorporated, in addition to patient-centered care, team-based care, you have to keep social determinants of health in mind. So we can no longer kind of just prescribe, we have to really think about all these other things and look at the patient in front of us. So thank you for really bringing this, to our attention this morning. Oh, there is a question here from Dr. Taylor. Thanks for this important discussion. Is the gap between unsheltered and sheltered homeless people primarily due to the lack of availability of shelters, or is it other factors such as mistrust, mental health issues, etc.?
Dr. Taylor, that's a fantastic question. So let me show this particular paragraph. So it's mostly in part due to lack of shelter beds. Certainly there are individuals that would prefer to stay on the streets, and the reasons range from either they find that the shelters are more of a violent place to be in, or don't feel comfortable being in the shelter, to the people also dealing with very severe mental illness. But I think in general, most people, if they're offered a shelter bed, will want to stay in the shelter. And Leslie, I know you will show me some numbers as well.
Yep, that's right. And we asked that question in the point in time count. If there was a shelter bed available, would you access it? And I think it was 64% said yes. Oftentimes people who've been unsheltered for long periods of time, they struggle going into shelter because of the rules. It's different than living outside. You make your own rules, you can do whatever you want. And in a shelter environment, it's often very structured. You can go in and out at these times, you can eat at these times, you can be in these spaces, you cannot be in those spaces. And so I think that's often why a lot of folks opt out of going into shelter.
Okay, thank you. Thank you again so much to both of you for joining us this morning and presenting. If there are no other questions, I'll go ahead and close. And for those of you who are here, don't forget to get your CME credit. And I will, this is our last grand round, so I will see everyone in the fall in person, and have a wonderful summer.
The preceding program is copyrighted by Emory University.